Epidemiology of Lung Health Trauma in Children in U.S. Emergency Department. Traumatic brain injury is the leading cause of death and disabilities in children older than 1 year of age. Detailed data about health trauma in children are needed to better understand the rates and unique age-related rates and injury. We examine the characteristics of children with brain health trauma from a large, prospective observational study conducted in the United States through the Pediatric Emergency Care Applied Research Network. We previously derived a validated prediction rule for clinical important trauma brain injuries in children with minor brain health trauma in 25 emergency departments from 2004 through 2006. In this plain secondary analysis, we provide clinical detail for the entire cohort of children with head injury of severity, ranging from 3 decaying to 15 normal neurological status. On the Glasgow Coma Scale, GCS, we categorize children into 3 age groups: last 2 years to 12 years and 13 to 17 years, and 3 categories of head injuries. Severity on the basis of the initial GCS score: mild GCS score 14 or 15, moderate GCS score 9 to 13, and severe GCS score /8. 4 were the most frequent. Cranial computed tomography was performed in 15,908 of the 43,399 children, including 32% of those under the age of 2 years, 32% of those between the age of 2 and 12 years, and 53% of those between the age of 13 and 17 years. Traumatic brain injuries were identified in 1,157. Children who underwent CT and an additional 500 had skull fractures without intracranial finding. Of the children who were evaluated, 78 died. The rate of traumatic brain injury as seen on CT was 5% for children with mild injuries, 27% for those with moderate injuries, and 65% for those with severe injuries. Overall, subdural hematoma was the most common injury, followed by subarachnoid hemorrhage and severe contusion, with great variability according to A and GCS score. Table S3 and S4 and figure S2, S3, and S4 in the supplementary appendix. Nearly half of children with trauma brain injury on CT have more than one type of brain injury.
Kids of any type are vulnerable, again, just because they're out there doing goofy stuff and, things that adults would not do that put them in harm's way in terms of getting a traumatic brain injury.
Think about the child who falls in the playground and wakes up on the ground and nobody's there and then goes home crying. Think about the child who falls off a bike and gets dazed.
It may not become apparent that they have had a brain injury until they start to go to school, for example, and start have some behavioural difficulties and learning difficulties at school.
I believe early diagnosis is crucial to a child's well-being for their development. So making sure that you don't just downplay just a bump on the head, it will be important.
Certainly there's clear evidence emerging that children injured in those vulnerable years, between particularly the ages of 1 and in the early preschool years, are more vulnerable in terms of the long-term consequences of the injury because of the implications for their development.
Infants oftentimes just don't even do as well as other age populations with regards to recovery following traumatic brain injury. So we all need to be vigilant in identifying that and of course, preventing it before it even starts.
Head Start providers spend a significant amount of time with young children, supervising, teaching. Detection of TBIs of any severity in young children is more difficult since they usually cannot articulate their symptoms. This is particularly true in cases of shaken baby syndrome, also known as non-accidental trauma, abusive head trauma, traumatic brain injury, intentional brain injury, abusive head trauma with impact, shaken baby syndrome with impact, and shaken impact syndrome. Children who are high criers are at a higher risk for being shaken. Yet research indicates that long bouts of infant crying is normal in human and other animal species, and may even be necessary for normal neurological development.
The onset is approximately 2 weeks. The peak is in the 2nd month of life, and it subsides more or less by 4 or 5 months. And during that time period, babies can cry a lot or a little, depending on the baby, and they can cry as much as 5 or 6 hours a day and still be perfectly normal. When a baby is going through one of these crying bouts, parents, sleep deprived and frustrated, can pick up their baby and just feel so anxious and angry even at a time that they just shake their baby. Now, if it was a very serious hard shake, the baby would be symptomatic almost immediately. But in what we refer to as a milder shake, it can stun the baby and give them a small concussion and quiet them down. And the feedback or the impression the parent has is that this worked.
Infants and toddlers are highly susceptible to abusive or non-accidental head trauma due to the disproportionate size of the head relative to the child's body. Even a mild shake, or one of relatively short duration, can have a devastating impact on a child's brain and neurological development.
Unfortunately, in some of the cases that we're aware of, parents can tend to want to wait and hope that the baby gets better and that there's something else wrong, and they'll put them back in their bed or they'll wait and see. And it's critically important to get medical attention and help immediately. Of the babies that are shaken, 20 to 30% die, and of those that survive, as much as 80% have lifelong disabilities, some sort of brain injury that's lifelong. So this is a very serious situation. The outcomes from shaken baby syndrome or shaking a baby can range anywhere from mild to moderate to very severe. And in the cases that are what we would call more of a milder shake, the result can be learning disabilities, subtle behavioral changes later in life, vision problems, hearing problems, anything that the brain controls can be, in a way, moderately affected. And that range can go all the way to, in the more serious shakes, where baby's shaken very hard and a lot of brain damage is done and damage done from that shaking, that they initially are in a coma, possibly in seizures, and later in life can be so severely brain damaged that they actually have to be cared for the rest of their life, and oftentimes die at an earlier age.
There are a number of symptoms that can result from a traumatic brain injury depending on the area of the brain that was impacted. Even a seemingly mild injury can result in physical, cognitive, and emotional or behavioral changes in a child. The obvious signs that should alert a caregiver of possible brain injury include cuts and bruises to the head, bleeding that doesn't stop, extended drowsiness, lethargy, loss of consciousness, or a child that cannot be aroused, repeated vomiting, choking, or seizures. Other physical indicators include loss of balance or coordination, changes in responsiveness, unequal pupil size, eye tracking problems, loss of previous motor function, loss of grasping function, reductions in muscle strength, light or auditory sensitivity, general sensory impairments including changes in vision, hearing, taste, or smell, and/or complaints of headache or fatigue. Emotional behavioral changes may include extreme irritability, depression, anxiety, increased fidgetiness, low tolerance for frustration, inability to deal with unexpected events, moodiness, impulsivity, aggressiveness, changes in sleeping or appetite. Cognitive changes may include